Welcome, everyone. My name is Marc Bonaca. I'm a cardiologist at University of Colorado, and I will be interviewing Professor Sam Tsimikas from UCSD, who has a hot topic to present at AHA and simultaneously published in JACC, looking at oxidized phospholipids and calcific aortic valvular disease. Welcome, Professor Tsimikas.
Marc, thank you very much for the invitation. Happy to be here.
Wonderful. Well, tell us, there's been a lot in the past around lipid lowering and aortic stenosis, some of it disappointing. And now there's this sort of future horizon thinking about lipoprotein little a and whether there's another modifiable target that we could potentially use to prevent progression. And you have this really thoughtful analysis looking at different types of lipids and how they may interact. And could you just give us a little bit of background on the question and how you went about answering this hypothesis?
Sure. Yes. Yeah. So you are very correct. There's been four trials with LDL lowering and aortic stenosis, and the best way to characterize them is they were neutral. And so back in 2015, when we were looking at the astronomer trial, we asked, perhaps, they would have been positive if LPA had been the target or it didn't change during the study. So we started getting very interested at that point in looking at this question. Now, Lp(a) has interesting mechanisms of action. One of them is that it carries highly inflammatory oxidized phospholipids. And oxidized phospholipids, when they're degraded, can make lysophosphatidic acid. And this is a procalcifying molecule. It's one of the most procalcifying molecules. So the idea was, well, if LPA is associated with aortic stenosis and it carries this procalcifying moiety, perhaps measuring these two molecules can give us some insights into the underlying mechanisms of what causes aortic stenosis. Now, oxidized phospholipids can also be generated by other ways, apoptotic cells, LDL, VLDL, but LP is a major carrier of it. And so we have ways to measure oxidized phospholipids. We call that test OxPL-apoB. And of course, LPA can be measured. And then we apply these two variables to two large data sets, the MESA study and then 4 randomized trials of aortic stenosis. So we can look at incident aortic valve calcium, prevalent aortic valve calcium, and also then look at the progression of pre-existing aortic stenosis. And so our hypothesis was that the OxPL, as measured in this assay, would capture all of the LPA risk and also capture additional risk from the other ways it's formed. And that's what led us to kind of test it whether there was a predictive variable in these data sets.
Well, that's no, thank you for explaining that. I think for many listeners that is extremely helpful. I mean, maybe could you tell us a little bit when you look at oxidized phospholipids, how much is it generated through LPA and how much proportionally through these other ways that you mentioned?
Yeah, if you look at studies where we have cell culture or we have ways to transfer the OxPL on and off LPA, or you look at correlation studies, it's actually highly variable. It can go from anywhere from 20% to 80% of the OxPL that we measure with this assay on ApoB particles are on LPA. The sicker the patients, the more likely it's going to be on other particles. The more stable the patients, it seems to then slowly accumulate on Lp(a). And so depending on the demographics, the setting, acute MI versus stable CAD versus some other variables that can affect it, it can vary, but I would say that on average, the majority of the OxPL on ApoB particles are carried by LPA, probably 50 to +%, somewhere in there.
Okay, very helpful. All right, so you had these two data sets and you explored this relationship. What were the key findings of your analysis?
Yeah, so the first study is we looked at MESA, and MESA, as you know, has aortic valve calcium measurements already. And we had already measured, LP was already measured in MESA. We measured OxPL-apoB in MESA in over 5,000 patients. And the first question we asked is, what is the relationship of OxPL-apoB and LPA to prevalent aortic valve calcium? So at the baseline exam. And when we look at a multivariable model using robust statistical analyses, and you put LPA or OxPL-apoB in a multivariable model by themselves with everything else, so age, sex, etc., that both predict the presence of aortic valve calcium. If you not put them in the same model, however, and these are continuous analyses, the per standard deviation, the LPA standard deviation, I'm sorry, the LPA hazard ratio declines, and the OxPL stays significant, suggesting that it's the OxPL that captures LPA risk plus additional risk that seems to be a better predictor if you put them in the same model and do an interaction test. So they're both predictive individually in a multivariable model, but when you put them together, the OxPL through the interaction test suggests it's a more potent predictor. And the way we kind of looked at that through that first analysis is that for any fixed amount of OxPL, the higher the LPA, the stronger the OxPL is a predictor. And the reason for that, I think, is this, that LPA is a genetically determined variable. OxPL is not necessarily a genetically determined variable. It's through oxidative stress, which could be genetic, dietary, environmental, but it's generated from a different set of pathophysiology. So if you have a patient that has genetically determined high LPA and they have additional reasons to generate a lot of OxPL, because the LPA acts as a sponge, you now have a molecule or a complex of molecules that have a kind of a two-hit hypothesis. The genetics of LPA and the oxidative stress of OxPL, they come together, and that measurement is encapsulated in the OxPL-apoB. And so that was kind of the explanation that we put together, or at least we conceptualized for why, when you put them in the same model, the OxPL seems to be a better predictor. So that was the first analysis. The second analysis was, we said, okay, since patients in MESA have a 9.5-year follow-up and have a second aortic valve calcium scan, what is the conversion rate of those patients that had zero calcium at baseline and now they have prevalent calcium, aortic valve calcium? And it was basically almost identical. If you look at individually, both LPA and OxPL are predictors. If you now do an interaction test with them together, the OxPL, again, seems to be a better predictor of risk as the LPA rises. So that was in an epidemiology cohort. We're talking about aortic valve calcium. We're not necessarily talking about real aortic stenosis with narrowing. So then we said, well, let's organize another set of data. And we had already done measurements of LP and OxPL in 4 studies: Saltire, Saltire 2, Astronomer, and the Ring of Fire study. So those 4, we put them together in a meta-analysis. And these patients had a pre-existing mild to moderate aortic stenosis. And then we asked the question, are they predictive of the progression of aortic stenosis, pre-existing aortic stenosis? And the answer is yes. If you look at them individually, again, in a multivariable model, they're independently predictive. If you put them in the same model, this time the LP comes out completely and only the OxPL stays significant. And so I think we have 3 sets of data all kind of telling us very similar findings. Both LPA and OxPL in a multivariable model predict the presence of aortic valve calcium, the progression of aortic valve calcium, and the progression of pre-existing AS. But the OxPL seems to be a more potent predictor when the LP is highly elevated, probably because it's an extra hit. So I think what it tells us is, big picture is, LPA is a target, a potentially modifiable target. OxPLs can be actually targeted with antibodies, and they can be bound and inactivated. And so ultimately in the future, we might want to ask the question, well, if we inhibit or knock down LPA, we inhibit OxPL, or we do both, what is the outcome? And that's where we're kind of trying to take this as we go forward therapeutically, not just with LPA lowering, but also perhaps with inhibiting OxPL.
Well, thank you. That's fantastic. And I was going to ask you the sort of therapeutic implications, because only about 20% of the population has a high LPA. So this isn't relevant just to them, because obviously people who have low LPA still get aortic stenosis. So then, targeted therapy for oxidized phospholipids then might be a broader therapy then for people, regardless of what their LPA is, or would it be in combination?
That's a great point. We're studying this in our lab right now in animal models. And as you know, animal models are very difficult to generate aortic stenosis in 2 years in a mouse. And Calvin Yang and his group is leading that effort. We're asking that exact question. So I think the OxPL is a broader target from the perspective that if you have an antibody that will bind the OxPL and LPA, it can also bind the OxPL that's generated on apoptotic cells, on LDL and VLDL. So if those are contributing to calcification and fibrosis, theoretically, if you can target the antibody to the right location, it should be, equally or more efficacious. Now, if it's not being able to get into the aortic valve leaflets where all the oxidized phospholipids are, then it could be that issue. So we really don't know. I think ultimately, they both could be targets. It doesn't suggest they're overlapping based on what we're seeing here, but it'd be nice to have a couple more studies to be able to see if this is a consistent finding, in additional studies. And so that's where
great.
I think the field should go.
That's very exciting. And then, in terms of, current day clinical practice, obviously we don't have available therapies that are targeted at either one. We do have PCSK9 inhibitors that do lower LPA, about 20-25%. Any data to suggest that might have any efficacy here?
Sure. I think, the data on PCSK9 inhibitors in aortic stenosis, there have been some post hoc analyses from Fourier, for example, suggesting there may be a benefit. But, these are problematic because a lot of the patients weren't enrolled to have aortic stenosis. Right now, what we do know is this, the way to lower LPA really well is through RNA therapeutics, either antisense or siRNA. And those can lower LPA 80 to 99%. And then we now have data actually on those drugs affecting OxPL. And the OxPL-apoB with pelacarsen goes down 88%. And there'll be data from some of the other studies that goes down in the 90s. And so at least the part that's on these particles can be easily modified with drugs that lower LPA. What ultimately we would need in the future is maybe to infuse antibodies that will bind these particles and detoxify them, which is another mechanism of benefit, not just get them out of the circulation, because they could go into the leaflets or some site where you don't necessarily want them accumulating. So we're going to have to see how that field progresses. But right now, I would say that PCSK9 inhibitors may have some effect. We do have data that's going to be published hopefully soon, that PCSK9 inhibitors also lower oxidized phospholipids, probably not to the extent that they're lowered by RNA therapeutics. So both of those approaches, I think, could be viable for addressing this issue. And I think the audience should also be aware, if not, that there's an ongoing trial right now in aortic stenosis with pelacarsen. It's called LPA Frontiers CAVS. It's already enrolled in patients. They have mild to moderate aortic valve stenosis. LPA levels are going to be elevated over 175 nanomoles per liter. They'll be randomized to pelacarsen monthly versus placebo, and that will read out in a few years. And so, of course, we'll measure oxidized phospholipids in that study, and then we can actually see whether we're seeing some differential effects of one variable versus the other, and then that will give us some insights into whether targeting both may be good or maybe just one or the other.
No, it's fascinating, very exciting future ahead. And as you said, that ongoing trial is enrolling people who already have aortic stenosis. I suppose one could even imagine a future where you could identify people at risk to prevent the onset of aortic valve calcification or stenosis altogether. Obviously, that would be several trials down the road.
Yeah. Sure, but it's as the field often goes that way. You start with the sickest patients, and then you work your way back. And the question then is, how big is your trial going to be? How many years do you need? Aortic stenosis is, relatively slow progressing on average, except if you have high LP and some other variables. But you still have time to intervene in these patients, maybe a decade earlier. And if you have a double therapeutic effect where you reduce, if the LP Horizon trial is positive and you have evidence that LPA lowering reduces cardiovascular risk, then if you have aortic valve calcium, you can kind of see where one drug can affect both phenotypes. So that would be really exciting to get there in the next few years to see if that's going to be feasible.
Very, very exciting. Well, Professor Tsimikas, I want to thank you for this wonderful analysis and for walking us through it. I think it is complicated how these things interact, but I think it really helps to elucidate some of the novel targeting that could be achieved in terms of the pathogenesis of aortic stenosis. Any final comments you'd like to make before we conclude our interview?
No, I think one of the issues we face in the field is often LP is not measured. And, I would just urge the readers that unless LP is measured, you don't know your patient is at risk for rapid aortic valve disease and progression. And so that's one thing. And also now oxidized phospholipids can be measured clinically. The assay is available. It's not used widely yet, but both of these biomarkers now can be checked, for the interested clinicians. So a lot of the folks that have aortic stenosis patients, I would urge them to check your LPA, and you'll be able to look very smart in front of your referring docs because you'll be able to predict who's going to progress faster and who's going to progress slower. So you can actually use this on a day-to-day basis in your clinic to help manage your patients.
Well, thank you for that. I mean, I do think that when you look at data broadly, not many folks are checking LP. Of course, the National Lipid Association put out a statement recommending, similar to the European guidelines, that everyone get it checked at least once in a lifetime. But I think a lot of clinicians sort of scratch their head and say, well, what do I do? And so that's very helpful advice that not only is it for athero, lower LDL targets, maybe for aspirin, but also for our aortic stenosis patients.
Exactly.
Well, wonderful. Well, thank you again for this wonderful analysis and for the interview today. And we'll conclude now. And I encourage people to read the full article and to look at the presentation from the American Heart Association.
Thank you, Mark. And I want to also thank the journal for being such a strong supporter of a lot of these types of studies. It's great to have the JACC lead the field in this area.